I am not going to spend trying to convince you how important fluid overload is, but rather think on a different paradigm about how we think about fluid balance, sort of a parsing out the complex relationship that occurs between positive fluid balance, negative fluid balance, and more importantly, even fluid balance or euvolemia, which is a physiologic state. So we tried to understand some of this from an epidemiologic perspective using our large data sets. I'm going to share with you some of the research findings. And I'll take you through each of those so that you understand, because some of this are going to be somewhat a little bit heavy epidemiology based talk. So the question is, does fluid overload really matter? And if it does, is negative fluid balance is really better? And there's been a lot of talk about trying to achieve how best to achieve negative fluid balance. And I'm going to try and convince you with some of the data that shows negative fluid balance is not a panacea for fluid overload. And there may be evidence that negative fluid balance may not be a good thing to achieve in all of our patients, but rather the goal should be to strive for euvolemia in whichever way we assess it. So in terms of disclosure, I have a research grant looking at intensity of monitoring of renal function in critically ill patients, and I'm also a PI of 2 other randomized clinical trials, none of which has anything to do with this talk. So fluid homeostasis is frequently disrupted in critically ill patients, especially with those with acute kidney injury. And positive fluid balance or negative fluid balance are extremely common in the ICU. It's been reported in about 40% of the patients in the ICU are fluid overloaded. It's been associated with a variety of poor outcomes, such as increased duration of mechanical ventilation, increased short-term mortality, and possibly lower renal recovery. The negative fluid balance, on the other hand, have also been reported in about 30% of the patients in the ICU, depending upon which study you look at, and has been associated with decreased duration of mechanical ventilation, decreased mortality, and improved renal recovery. So if you look at the negative fluid balance and the current recommendations, for example, ventilating patients with ARDS, the recommendations are that we should strive and achieve negative fluid balance in order to get them off from the ventilator. And it's also been reported to be associated with lower mortality. But the question still remains, in comparison to what? So positive fluid balance is clearly associated with bad outcomes in comparison to what? Who are the comparator population that we're talking about? If we are taking about patients with no fluid overload, that includes patients who are euvolemic, who remain in a physiological state, but also includes patients who are in negative fluid balance. So it's important to tease out who we are comparing with. Whereas the prior studies have all looked at positive versus negative, or positive versus no positive, but not really parsing out the other 2 groups of patients, which is euvolemic patients, as well as patients who are in a negative fluid balance. So we wanted to look at what is the exposure of positive or negative fluid balance in relation to shift to euvolemia on long-term outcomes. So many of these studies looked at short-term outcomes, and we wanted to focus predominantly on 1-year outcomes. And this cartoon has been shown in a number of times in this presentation, where the fluid overload or the volume is a function of that the patient gets is the function of how much fluid is given, but also in terms of which time it is given, and also in terms of complication. If you give too much of fluid, then you're likely to end up with organ edema. If you give less fluid, then you are likely to end up with ischemia. And so there is this time relationship and volume relationship. So a certain volume may be right at a certain time, but if you give it late, it may be problematic. Of the same volume that is beneficial initially, if it hangs out for a longer period of time, may be harmful in that particular patient. So nevertheless, these are complex, and in each individual patient, there is an optimal sweet spot that we try to assess and find clinically, but in practice, this is really difficult to achieve. So fluid overload affects every organ system, and this has been nicely illustrated in this cartoon by John Prowl and Ronaldo Bellomo's group, suggesting that every organ system in some form or the other are evaluated. We don't think about fluid overload when someone in the ICU gets delirious. We don't think about fluid overload when someone thinks about, suddenly has a cardiac arrhythmia. Yet there's evidence to suggest that even subtle forms of fluid overload are associated with pulmonary congestion, hepatic congestion. We recently lost a liver patient after a live donor liver transplantation, primarily because the allograft was so congested from the fluid overload that subsequently resulted in organ dysfunction and retransplantation for that particular patient. Furthermore, fluid overload has also been associated with tissue-poor wound healing, as well as gut edema resulting in impaired tolerance of nutrition. Also, it's been postulated that the glomerular filtration pressure that's around is only about 10 millimeters if you account for the differences between the hydrostatic pressure as well as the oncotic pressure and the intercapsular pressure. So it's very easy to obliterate that 10 millimeter difference with a fluid overload to stop glomerular filtration. So it's been proposed that fluid overload impairs renal recovery in a wide variety of patients. So observational study have nicely shown in the past that not only in all patients, but also in patients receiving renal replacement therapy, fluid overload, when compared to no fluid overload, is associated with poor outcomes. And again, the key point about here is that what does no fluid overload really mean? And this is also nicely shown that there's a dose-response relationship where the higher the fluid overload, the bad the outcomes are, both whether you are dialyzed or not dialyzed. So, however, some of the residual questions still remain related to fluid overload. What does the outcomes related to positive fluid balance mean in terms of relationship with negative fluid balance? And what is the whether fluid balance any long-term outcome relationship? Many studies only looked at short-term. And many of the studies, if you look at especially the ICU studies, did not adequately control for severity of illness or indication bias for which the fluid is actually given, so which is an important reason. And many people have argued it's not the fluid overload that associated with bad outcome, it's the indication that led to the fluid overload that was associated with bad outcomes. So what about negative fluid balance? So for example, this study from Dr. Bellomo's group that looked from the post-hoc analysis of the renal trial looked at association between negative fluid balance and in relationship to positive fluid balance on outcomes. And what they found was negative fluid balance was as little as minus 500 mLs was associated with the 70% reduction in mortality. So observational studies obviously overestimate treatment effects, but 70% is a very high treatment effect that one would expect from a mere 500 ml reduction in fluid balance. So they also looked at renal recovery and found that negative fluid balance was associated with improved renal recovery. So we wanted to examine this again to see in terms of whether this is really true in terms of long-term outcomes. And so our hypothesis was that exposure to positive fluid balance compared with even fluid balance was associated with increased risk-adjusted one-year mortality. And that negative fluid balance is associated with lower one-year mortality, and that among patients receiving renal replacement therapy, positive fluid balance is associated with renal replacement therapy dependence, and negative fluid balance is associated with RRT independence. So we used a large data set at University of Pittsburgh Medical Center of critically ill patients. And we took over an 8-year period, we took about 45,000 patients, and we excluded many patients in whom weight were not recorded. ICU stay was less than 48 hours, primarily to exclude people who came and died, where fluid overload is unlikely to influence the outcome under those circumstances. We also excluded patients with renal transplantation, chronic dialysis, anybody with severe chronic kidney disease, and also in whom input-output data was missing. We ended up with an analysis cohort of about 18,000 patients. And shown here is the relationship between cumulative fluid balance and crude hospital mortality. As you can see in this cartoon, there's a nice dose-response relationship, but I'd like you to focus at the extreme end where the mortality somewhat goes up when patients are in extremely negative fluid balance. And I'd also like to point out this area where the mortality is somewhat lower, but somewhat in the middle grounds where we chose as 0 to 5% as an even balance or euvolemia. And we said less than 0% is negative fluid balance and greater than 5% as positive fluid balance. Prior studies have examined only greater than 10%. For this study, we looked at just greater than 5%. And we defined cumulative fluid balance as daily input minus output times 100 divided by hospital admission weight. And what we found was the negative fluid balance was prevalent in about 26% of the patients. Even fluid balance was prevalent about 28%, and positive fluid balance about 45%. So pretty consistent with the reported literature in terms of prevalence of both positive as well as negative fluid balance. If you look at the mean amount of fluid balance in these patients, we found that obviously patients with positive fluid balance were at the end of 72 hours, they were 5.7 liters positive. At the end of 7 days, they were 7 liters positive. Patients with negative fluid balance at 72 hours were at the minus 900 mLs negative, and at 7 days, minus 1.7 liters on a negative balance. So we then looked at the relationship between fluid balance and 1-year mortality by the 3 groups. And what we found were patients with positive fluid balance greater than 5% had an incrementally higher risk of death when compared to euvolemic or even fluid balance patients, as well as with the patients with negative fluid balance. So this is not, this is kind of saying world is round. But then we adjusted for indication bias, in which we took each of these patients in each of those 3 groups and propensity matched them to generate about 2,300 trials in which patients look exactly the same in all the baseline characteristics except the outcomes. And we used a number of about 30 variables to propensity match these individual patients. And shown here are the outcomes associated with each of those fluid groups. And you can see that positive fluid balance was associated with increased increased length of ICU stay. There was not a lot of difference between the risk of AKI between the 3 groups. RRT requirement was about 2.4%, and the hospital mortality was about 14% in the positive fluid balance group, and 1-year mortality was 30%. If you look at the negative fluid balance group, the hospital mortality was 5.8% and 1-year mortality was 22%. But if you compare it with the even fluid balance group, you would say that there is actually no difference in 1-year mortality. And I'll show just in a second why some of the way in which we analyze this data would mask the effects of the negative fluid balance on mortality. So in terms of renal recovery, we found no difference after propensity matching between the 3 groups. And this study, renal recovery was defined as being alive and independent of renal replacement therapy at 1 year after ICU admission. So in order to tease out the risk of death over a time period in these patients, we build what we call a GRACE model, which estimates risk of death over 7 time intervals. You can specify the number of time intervals, but we specify 7 time intervals and 6 nodes, and it estimates the hazard ratios for each of those time intervals. And shown here are the hazard ratios on the y-axis, adjusted hazard ratios on the y-axis, and shown here on the x-axis are the days of ICU admission. The solid line indicates the confidence interval, and the risk estimates, and the dashed lines indicate the 95% upper and lower confidence intervals. And as any estimate above hazard ratio above 1 means that positive fluid balance or exposure variable is associated with increased risk of death. Less than 1 means it's associated with lower risk of death. And you can see here in this study, the positive fluid balance was, when compared with even fluid balance, was significantly higher, associated with higher risk of death. But this risk was not constant over time. The risk was higher during the earlier period of days, about 175 days, but then it sort of risk came down. But nevertheless, it was persistent up to 1 year. And this was present after we adjusted for about 30 different variables that are shown here that are likely to confound the association between exposure to positive fluid balance as well as the outcomes. Moreover, the interesting thing that we found out was we took out patients with AKI, which is the population at risk for fluid overload. When we looked at non-AKI population, we found the same thing. And in which positive fluid overload or fluid balance was associated with increased risk of death up to 175 days, after which this risk was attenuated. But nevertheless, this was very surprising, but even, why are these patients dying is still something that are sort of puzzles us, because this is after adjusting for all of these characteristics. And if they don't have AKI, why can't they regulate their fluid balance? But nevertheless, I want to point out that even if they did not have AKI, there's an increased incremental risk of death associated with positive fluid balance. What about negative fluid balance? And we found some interesting findings here. And what we found was negative fluid balance in relationship to even fluid balance had a variable relationship with the outcome. So if you look at this graph, you can see up to 45 days from ICU admission, negative fluid balance was associated with lower risk of death. But subsequently, from 45 days up to 200 days, there was no association. That's because the confidence interval is crossing that red line that goes either way. But after 200 days, there was an incremental sort of a uniform risk of death that persisted up to 1 year. So this was really puzzling for us, because if we are saying that we need to get patients on a negative fluid balance, our data is telling us, yes, the negative fluid balance may be beneficial in the short term, but in the long term, it may not be beneficial. And we looked at this in a variety of ways. We did several sensitivity analyses looking at fluid balance, adjusted serum creatinine to define AKI, since fluid overload confounds the assessment of AKI. We also changed the fluid balance threshold, going to defining negative fluid balance as -5 and then greater on. And we also looked at different time periods from ICU admission, from 7 days to 72 hours. But nevertheless, we found the same thing, that no matter how you look at it, negative fluid balance was associated with short-term mortality, protective for short-term mortality, but associated with the increased risk of death in the long term. And this is important because if you combine both of these estimates together in any models, for example, the traditionally used logistic model or a Cox model, you may not find this because the effect would cancel out each other, and you will likely to conclude that there's actually no effect. Furthermore, if you compare negative fluid balance with a positive fluid balance, clearly negative fluid balance was protective. And this is what all other studies have shown, that when you compare with positive fluid balance, negative fluid balance is clearly beneficial. But is positive fluid balance the right comparator to focus on is really the question that we should be thinking about. What about RRT? When we looked at the RRT subgroups, both within the negative fluid balance categories as well as in the positive fluid balance categories, the effects were there was no relationship between any of these fluid balance as well as the outcome relationship. In other words, there was no increased risk of death or decreased risk of death in either of those positive or negative fluid balance in comparison with even fluid balance. However, we found a significant interaction between RRT among patients with fluid balance. So if you are fluid overloaded and you received RRT, you're more likely to survive when compared to the same degree of fluid overload and did not receive RRT. And you can see here the hazard ratios are less than 1, suggesting that there's a huge interaction between fluid balance and RRT, suggesting that RRT compared to no RRT use in patients with fluid overload was protective for mortality, that at least persisted up to 175 days in our analysis. So when we looked at renal recovery, we found there was no signal at all. No matter how you look at it, there was no, when you compare it with even fluid balance, positive or negative fluid balance had no association with renal recovery, both in all the overall group of patients as well as in the survivors. So we're thinking about why, if negative fluid balance may not be as so good, why might be that negative fluid balance may be not so, may be harmful. And I just want to highlight this, and we don't know the mechanism because these are observational studies. But I wanted to point out this interesting finding from the FACT trial. If you look at the FACT trial, patients randomized to conservative fluid management came off the ventilator much quicker, but there was no overall difference in mortality between the liberal fluid management strategy and the conservative fluid management strategy. But if you look at the 1-year analysis of neurocognitive function in survivors of ARDS from the FACT trial, patients who were randomized to a conservative fluid management strategy had a higher risk of neurocognitive dysfunction in all of those executive function, verbal fluency, and neurocognitive impairment. And that's still not unaccounted for. So I don't know. I mean, I can say that, why this happens, but maybe drying out patients may not be the good thing. And it may likely to cause hypotension, ischemic organ injury, subtle increased inflammatory response may all have a long-term effect. Short-term patients don't die in the ICU. We know this all the time. We know how to keep patients going on for 30 days, which is the reason why when you dry these patients out, in all of these models, you see that negative fluid balance is associated with protective for mortality because we never let these patients die while they're in the hospital as well as in the ICU. But in the long term, when they go out, there's an increased risk of death. And obviously, this needs to be studied and carefully, examined in other studies. But I have my own reservations about extremely drying out patients based on this research. So I'd like to conclude by saying positive and negative fluid balance are extremely common in ICU patients. The outcomes from fluid balance depends upon the comparator population, who you want to compare it with. Especially if you compare positive compared with even fluid balance and negative fluid balance, clearly positive fluid balance is associated with 1-year mortality. On the other hand, negative fluid balance has a variable association. It's associated with lower risk in the short term, but in the long term, it may be associated with increased risk of death. And we found no association between fluid balance and renal recovery. With that, I'd like to acknowledge some of my fellows and statisticians and John for helping me to get some of this work done. Thank you.
Thank you very much, Raghi.